Hi, I'm Jim Hermiller from Indianapolis, and it's a great privilege to be here today with Dr. Marty Leon, and we're going to talk about TAVR. And Marty needs no introduction. He clearly has been really the tip of the spear when it comes to all things cardiovascular, transcatheter, but in particular TAVR. And we're coming up, it's just a little more than 2 weeks on the 20th anniversary of the first TAVR implant. And you were there really from the beginning. And I'd love to hear your memories, your thoughts about how this all took off.
Well, thanks, Jim. It's really a pleasure to chat with you. And yeah, certainly I have such strong positive feelings about SCAI. This is a special celebration, the 20-year anniversary of the first inpatient TAVR experience. I recall vividly some of those early days. I had an opportunity to work closely with Alain Crebier. He's been a good friend since the 80s. I shared his frustrations with the relative failure of balloon aortic valvuloplasty. We had an emerging stent era and brainstormed about possibilities of new devices. Worked together with some very interesting engineers and formed a startup company at the end of the 90s called Percutaneous Valve Technologies. And that for us really was the beginning of the story. Alain really was the test pilot. He was the aggressive clinician with tremendous experience in valvular heart disease, did the first valvuloplasties, and was really committed to this project. He did a lot of the animal work. We did a lot of the design work in collaboration, and worked closely on deciding on that first patient. And I'd like to remind people that the first case was a man in his mid-50s. He had bicuspid aortic valve disease. Most people forget that. An ejection fraction of 10% with a mobile LV thrombus, had no peripheral access because he had occluded iliacs on both sides and was in cardiogenic shock, having had 3 recent previous balloon valvuloplasties with rapid recurrence. So that was the first case that was done. It was done without general anesthesia. It was done without transesophageal echo using the antegrade approach, which is extremely difficult. The patient arrested and was in ventricular fibrillation when the valve was deployed. And it was an early version, I would argue a prototype that was crimped by hand, basically, and a crimper on a commercial balloon as it was deployed with a dramatic response. This patient literally woke up and the hemodynamics were as expected, and he recovered fairly quickly. And it was a striking proof of concept first case. So we have very, very vivid memories about this. And so that's the way things started. But I will tell you, in the beginning, it started really as a procedure for the without option patient, really the sickest of the sick patients. And we had no idea that this could be extended to a much larger patient population.
Yeah, that's just, that's remarkable. And then, it's just a few years and, Dr. Webb and Eberhard started doing transfemoral, and then it's sort of just bam, it's like a big bang.
Yeah, I will say that there were so many people involved, and it's important to mention some of the people you mentioned. Eberhard is a cherished friend, and he was doing cases in India a few years later. John Webb was really responsible for transitioning us from the transfemoral venous approach, the antegrade approach, to the retrograde femoral artery approach, and was instrumental in that. He helped develop the transapical approach. Mike Mack was working in Leipzig and helping to develop the transapical approach. So there were many people, I think, in the early days who contributed a lot to this technology. And we were very fortunate that both the balloon expandable and the self-expanding platforms committed themselves to very high clinical practice and to the accumulation of clinical evidence, which resulted in the many clinical trials that followed.
It impresses me as sort of the cadence of not just sort of the engineering and better devices, but the cadence of the science. And you were the head of both of those. And just maybe comment on how rapidly, the velocity of how basically the studies came out very disciplined and sequentially as well as, hey, we're miniaturizing the devices. We've got leak solutions. We can redeploy the imaging. I just love to hear your kind of thoughts about it.
Yeah, I think, Jim, that it was an interesting, we tried to plan this and we tried to plan the dissemination. We knew that aortic valve surgery is very, very good for the vast majority of aortic stenosis patients. And for us to be in any way reasonably competitive, we had to have evidence and we had to have technology that would justify going away from an open surgical approach. So we fully embraced a heart team. I think that was one of the vestiges of this that has remained. So we worked closely with the surgeons in the beginning. In fact, we trained many surgeons in these techniques. That was a part of it. I think also the commitment to evidence generation was key, and I give the FDA a lot of credit for helping us to be able to form these trials. So we did de-escalating based upon risk strata, randomized clinical trials, and we did it, as you say, in a very disciplined way, constantly increasing the number of sites and the number of people who became involved. I think it's important to recognize that we published everything. From the Partner Series, there are over 200 manuscripts, Jim, 10 of them in the New England Journal of Medicine and 3 in the Lancet. There's never been a portfolio of trials in the same genre with that level of academic commitment. But we published not only the good stuff, we were openly critical of ourselves. We pointed out the issues with paravalvular leak, with strokes, with vascular complications, with conduction abnormalities. And I think that went hand in hand with the technology development, because it really allowed the industry sponsors to recognize some of the weaknesses, and they kept iterating. They realized we need low profile devices. We need something to eliminate paravalvular leak. We need better sizing algorithms. We need to manage conduction better. So I think that self-critical approach was extremely helpful. And again, I have to credit our industry collaborators and the FDA for allowing us to be so honest with sharing the data.
Yeah. So now we, fast forward to where we are today, low risk, essentially 65 and over, the most recent guidelines, TAVR sort of is the default, unless there's some anatomic issues. Where is this going? Where do you see we need to improve? Not only on the data, but also where we have to go with these devices to basically make it for anyone with aortic stenosis, essentially.
Well, it's a great question. As good as we try to be, I'm sure there are going to still be patients that need surgery. A lot of patients have concomitant cardiovascular disease. Surgery is going to be a better thought, at least for the time being, in the really young patients, particularly the bicuspids. We don't have a long-term solution with the bioprosthetic valves that we currently are using. So I think we need to be reasonable. But I'm fairly aggressive, Jim. And, I give this new talk that I call upstream management of aortic stenosis, where I'm saying that we've been too conservative. And I had this discussion with Gene Brownwald. And the reality is using symptoms as a trigger for treatment is a mistake. And we need to get into a completely different mode of how we make decisions about what the trigger point for treatment should be, especially if you have a less invasive and low complication prone procedure like TAVR. So, we've gotten involved, as in large studies in severe asymptomatic AS. We're leading the charge in the PROGRESS trial, which is moderate AS, and there are other studies in moderate AS. So we think that the upstream treatment to less severe and less symptomatic patients is the right decision, as long as we do it again with good evidence and with careful thoughtfulness on which kinds of patients. We also think that the technology has reached a little bit of a plateau. It'll continue to evolve. The main changes in the future you'll see, things like commissural alignment are interesting and important. Getting better, even more on reducing conduction abnormalities. And certainly I think the next generation is going to be new leaflet materials to try to see if we can extend the longevity of these valves so the durability is no longer an issue. And I think that we're on the verge of making some significant breakthroughs in that space as well. So much more to be done. I would tell my good friend Alain Cribier that we're not done yet, that even after 20 years, we'll still be busy, I think, with many new ways to extend indications and to reduce complications and to allow this procedure to continue to be a central standard of care for most patients with aortic valve disease.
Yeah. Well, this is just my final question. You've been, again, at the head of this, really democratizing this therapy. It is a therapy that can be, employed by, interventional cardiologists, surgeons in a routine way. What do you see as far as the training? What do we need to be focusing on as far as teaching those that are doing TAVR today?
Yeah, that's another great question. I think, if there's anything to me, which is the secret sauce in TAVR, is just what you said. The fact that we've been able to democratize and disseminate the technology and make it easy enough to apply with proper training so that many different environments can get good results. There are over 800 centers in the TVT registry right now in the US alone. So I think that to me is remarkable, and that I think is a testimony to the excellent training that people have done. But I will say that we still have many underrepresented populations. We still have many fringe areas that are not well trained. We still have access issues in terms of providing this technology to many people in different environments. And I think that even though the training is good, the ongoing training and the remedial efforts to take centers that aren't performing at the highest standards needs more work. So TVT is great at accumulating good benchmark information. We need to close the loop, and we need to identify centers and sites where the results are not as good, where we can go back and retrain and provide the remedial opportunities for people to elevate beyond what we consider to be an acceptable standard. So there's more to be done, and I think the training is getting more sophisticated. A lot of it can be done virtual, and I think it's got to be an ongoing commitment from both the sponsors and from the societies.
Well, Marty, thank you. I just can't thank you enough. SCAI can't thank you enough. Your words of wisdom, your experience, your leadership really has brought us where we are today with TAVR. So thank you, and look forward to talking more in the future.
Thank you, Jim. It's been a lot of fun, and everybody should go to SCAI this year. It's going to be a great meeting, and we can all celebrate together the 20-year anniversary of the first TAVR.